Today's session will be talking about implementation of enhanced barrier precautions for long-term care facilities. We're here on behalf of Project Firstline Rhode Island and the Center for Acute Infectious Disease Epidemiology at the Rhode Island Department of Health in partnership with the Centers for Disease Control and Prevention, CDC. Thank you all for joining us today. And before we begin, I'd like to direct your attention to the chat and introduce Abby Anderson. She is our Project Firstline project assistant, and she'll be posting resources for you throughout the webinar in the chat. And our whole team is here in support of this webinar. And if you'd like to take a minute, go ahead and introduce yourselves in the chat. Tell us your name and your organization. And I'm glad to meet everyone. And if you're returning, glad to see you again. Just a few reminders before we get into the content. We have a lot of material to cover today, and I know many of you have questions surrounding Enhanced Barrier Precautions, or EBP, and hopefully the webinar will address most of them. We will have a brief question and answer session immediately following the webinar, but if we're not able to address them live, please leave your email so we can address them later via email. Everyone is muted. At the bottom of your screen, you'll see the Q&A box. Please post all your questions in the Q&A box. That way we can make sure we get to all of them, either live or via email. And the chat box is available to connect with our behind-the-scenes team members. And if you'd like to be included in our distribution list, please leave your email there as well. So my name is Stephanie Doyle. I'll be your host and your presenter today. I'm an infection prevention training liaison for Project Firstline Rhode Island and a community public health nurse at the Center for Acute Infectious Disease Epidemiology at the Rhode Island Department of Health. I've been practicing healthcare professionally over 20 years and a nurse for 17 of those years. I've worked in many different roles and have a range of different nursing experience, which has led me to my practice in public health and education. And I'm joined today by Dr. Alexis Kearney, the Project Firstline Medical Director. Dr. Kearney, welcome, and thank you for being here today.
Good morning, everyone. Thanks for being here. Excited to have all of you.
So today we're going to talk about multidrug-resistant organisms and ways to prevent the spread of infection caused by these organisms with the use of enhanced barrier precautions. As healthcare professionals, it is our duty to maintain high standards of care to protect the populations we serve who are most vulnerable during their healthcare experiences. Infection prevention and control is important to stay at the forefront of the care we provide. It is vital to keep infection prevention and control a priority to keep our patients, ourselves, and our colleagues safe. I'd like to thank our partners within the Division of Emergency Preparedness and Infectious Diseases. From the Center for Acute Infectious Diseases, the Healthcare Associated Infection Team, and from the Center for COVID Epidemiology, the COVID Prevention Field Team, and the Long-Term Care Facility Group. And just a reminder, this nursing continuing professional development activity is approved for 1 contact hour credit by the Northeast Multi-State Division Education Unit, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. And in order to receive your CNE credit, the following steps must be completed. So you must fill out that pre-session survey, and that will close shortly into the webinar, so make sure you do that. And then attend the live training. And then you must complete the post-session survey. And if you're only opting for a certificate of training, you can stop there. But if you'd like to go on and receive a continuing education credit, you must complete the post-session quiz, which will be emailed out to you tomorrow. All right, for our agenda today, we've done our welcome and our introductions. We'll go over our learning objectives. We're going to define multi-drug-resistant organisms, or MDROs, and discuss the healthcare implications of MDROs in long-term care facilities. Then we'll dive into infection control and prevention with a focus on enhanced barrier precautions. We'll have some time to reflect, go over key takeaways, and we'll have some announcements at the end and a brief Q&A. And then we have a short end of session feedback poll for you at the end. All right, so here are our learning objectives. At the end of today's session, you will be able to define multi-drug-resistant organism, explain the impact and burden on long-term care facilities, understand how multi-drug-resistant organisms spread and lead to outbreak, and understand the need to implement Enhanced Barrier Precautions, or EBP, and learn some tips and tricks on how to be successful with implementation. Multidrug-resistant organisms, or MDROs, are defined as microorganisms, predominantly bacteria, also fungi, that have become resistant to one or more classes of antimicrobial or antifungal agents. Examples of MDROs targeted by the CDC include pan-resistant organisms, carbapenemase-producing, carbapenem-resistant Enterobacterialis, carbapenemase-producing, carbapenem-resistant Pseudomonas, carbapenemase-producing, carbapenem-resistant Acinetobacter baumannii, and Candida auris. And we'll get into a little bit more detail on those targeted organisms. Additional epidemiologically important MDROs may include, but are not limited to, methicillin-resistant Staphylococcus aureus, or MRSA, which I'm sure you're all familiar with, extended spectrum beta-lactamase-producing Enterobacterialis, or ESBL, vancomycin-resistant Enterococci, or VRE, just to name a few. And although C. diff is not often resistant to antimicrobials, it is sometimes grouped into this category due to its potential significant impact on long-term care facilities. Some of these organisms are considered an urgent public health threat, as published in the CDC's 2019 Antibiotic Resistance Threats Report. So we'll get into a little bit more detail on these MDROs of significant importance that are targeted by the CDC. First, we'll talk about Candida auris and what you need to know, also referred to as C. auris, and it was first identified in 2009 and has quickly become a cause of severe infections around the world. It is often multi-drug resistant, with some strains resistant to all three available classes of antifungals. It can cause significant outbreaks in healthcare facilities, and some common healthcare disinfectants are less effective at eliminating it. It can be carried on patients' skin without causing infection, allowing silent spread to others. We have our carbapenem-resistant Enterobacterialis, or previously referred to as Enterobacteriaceae. There was a name change back in 2020, and we now refer to CRE as the Enterobacterialis as the name of the scientific order. And the Enterobacteriaceae is now a family within that order, so you may see those interchanged. So these CRE affect patients who require devices and who have a history of MDRO, patients taking long courses of some antibiotics, and approximately 30% can carry mobile genetic elements that are easily shared between bacteria. And these elements or mechanisms can produce enzymes which make carbapenem antibiotics ineffective, which are in some cases the last resort antibiotic. Carbapenemase-producing CRE make enzymes called carbapenemases that inactivate carbapenems and other beta-lactam antibiotics, including penicillins and cephalosporins. The presence of carbapenemase is usually sufficient to cause resistance. Many carbapenemase genes are on mobile genetic elements that can be transmitted from one bacterium to another, thereby spreading resistance. Enzymes can rapidly spread resistance that destroy important drugs. And our next urgent level threat is the carbapenem-resistant Acinetobacter, and most commonly what we're seeing is the Acinetobacter baumannii, or referred to as CRAB. It can cause infections in the blood, urinary tract, and lungs, or in wounds in other parts of the body. It can also colonize or live in a patient without causing infections or symptoms, especially in respiratory secretions or open wounds. And these too can carry the mobile genetic elements that are easily shared between bacteria, which make most antibiotics ineffective and rapidly spreads resistance that destroy important drugs. Some Acinetobacter are resistant to nearly all antibiotics, and few new drugs are in development. So how do these bacteria and fungi fight back against these antibiotics? So antibiotics are used to fight germs, but germs fight back and they find new ways to survive. Their defense strategies are called resistance mechanisms. Only germs, not people, become resistant to antibiotics. To survive, germs can develop defense strategies against antibiotics and antifungals called the resistance mechanisms. Some examples of how this occurs are germs can actually change cell function to resist antibiotics, change or destroy the antibiotics with enzymes, proteins that can break down the drugs, like we spoke about the carbapenemase enzymes, restrict access by changing entryways or limiting the number of entryways, and change the antibiotic's target so the drug can no longer fit and do its job. And they also can get rid of antibiotics using pumps. We do have a link to this infographic that Abby can share in the chat, so you can have the entire infographic to look at there. So DNA tells the germ how to make specific protein, which determine the germ's resistance mechanisms. Bacteria and fungi can carry genes for many types of resistance. When already hard to treat germs have the right combination of resistance mechanisms, it can make all antibiotics or antifungals ineffective, resulting in untreatable infections. And it's alarming that antimicrobial resistance germs can share their resistant mechanisms with other germs that have not been exposed to antibiotics or antifungals. So how are we as healthcare personnel on the front lines going to stop the spread of these harmful organisms? First, let's review where these germs live. Remember, germs can live in the body or in the environment. In the human body, we have skin, the gastrointestinal system or the gut, the respiratory system, and blood. The skin or a wound can be colonized with a resistant strain of Pseudomonas, for example. Can you think of any other resistant organisms that can live on the skin? In the healthcare environment, we have water and wet surfaces, dry surfaces, dirt and dust, and devices. These organisms can live and thrive in any of these reservoirs. Although Enhanced Barrier Precautions focuses on high-contact resident care activities, it is important to know that germs can remain in the environment for long periods of time as well. Devices can harvest bacteria and facilitate spread from resident to resident, making it important to utilize that extra layer of protection, or EBP, to prevent transmission from an environmental reservoir. Gown and glove use by EVS, environmental services professionals, or others responsible for cleaning and disinfecting at the point of care should be based on facility policy and for anticipated exposure to body fluids, chemicals, or contaminated surfaces. It is important to remember gown and gloves should be worn by EVS personnel when cleaning and disinfecting the rooms of residents on contact precautions. So when you understand where germs are found and how they can be moved from place to place where they can cause harm, you can recognize when they can be spread and decide what you can do to protect yourselves and your residents. In most cases, there are 4 main pathways for germs to be spread in healthcare. The first is through touch. That usually involves the skin, especially the hands, but it also happens with devices which touch different people and surfaces. Another pathway for germs is through breathing in. A third is through splashes or sprays of blood, body fluid, or water from a sink or other source. Germs in those splashes or sprays can get into a person's eyes, nose, or mouth, or into a cut or break in the skin and cause infection. The last common pathway for germ spread in healthcare is through clinical care tasks that bypass or break down the body's natural defenses, like when a patient's skin has to be broken to insert an IV. That creates a pathway for germs to enter the body. So now we'll get into some infection control actions that we can use to stop the spread of these MDROs. So first I want to review standard precautions. Standard precautions is a group of infection prevention practices that apply to the care of all residents, regardless of suspected or confirmed infection or colonization status. They are based on the principle that all blood, body fluids, secretions, and excretions, except sweat, may contain transmissible infectious agents. Proper selection and use of personal protective equipment, or PPE, such as gowns and gloves, is one component of standard precautions, along with hand hygiene, safe injection practices, respiratory hygiene and cough etiquette, environmental cleaning and disinfection, and reprocessing of reusable medical equipment. Use of PPE is based on the staff interaction with the residents and the potential for exposure to blood, body fluids, or pathogens. For example, using gloves when contact with blood, body fluids, mucous membranes, non-intact skin, or potentially contaminated surfaces or equipment are anticipated. More details about standard precautions is available as part of the core infection prevention and control practices for safe healthcare delivery in all settings. And Project Firstline Rhode Island does have detailed webinars for these standard precautions as well that are available for your access. So in review, standard precautions applies to all residents. PPE is used for these situations. Any potential exposure to blood, body fluids, mucous membranes, non-intact skin, potentially contaminated environmental surfaces, or equipment, depending on anticipated exposure, gloves, gown, or face mask or eye protection should be used, and there are no room restrictions. So our next infection control action to combat these multi-drug-resistant organisms is antibiotic use. Antimicrobial stewardship, Antibiotic use is a major risk factor for developing drug-resistant infections. More than 2.8 million antimicrobial resistant infections occur in the United States each year, and more than 35,000 people die as a result. Ensuring appropriate use of antibiotics is one of CDC's core strategies to combat the threat of antimicrobial resistance. Antibiotic stewardship is also important to ensure equitable access to high-quality health care and to optimize treatment of infections and patient safety. So why is antimicrobial stewardship so important? It improves patient outcomes, reduces microbial resistance, and decreases the spread of infections caused by multi-drug-resistant organisms. And as healthcare personnel, we must advocate for the best outcomes for our residents. Gaining knowledge about antimicrobial stewardship can empower us to encourage prescribers to make informed decisions about treatment options especially for those who are at most risk for multidrug-resistant organisms. Improving the use of antibiotics in healthcare to protect residents and reduce the threat of antibiotic resistance is a national priority. Antibiotic stewardship refers to a set of commitments and actions designed to optimize the treatment of infections while reducing the adverse events associated with antibiotic use. The CDC recommends that all nursing homes take steps to improve antibiotic prescribing practices and reduce inappropriate use. Antibiotics are among the most frequently prescribed medications in nursing homes, with up to 70% of residents in a nursing home receiving one or more courses of systemic antibiotics when followed over 1 year. Nursing homes are encouraged to work in a stepwise fashion, implementing 1 or 2 activities to start and gradually adding new strategies from each of the 7 core elements. Any action taken to improve antibiotic use is expected to reduce adverse events, prevent emergence of resistance, and lead to better outcomes for residents in this setting. All right, so now we're going to get into enhanced barrier precautions, what we've all been waiting for. And I'm going to show you a brief video that the CDC has published recently to explain a brief overview of enhanced barrier precautions.
As long-term care professionals, our jobs make a difference. It's not always easy. Each day can bring new challenges. But the effort we put in can be life-changing for someone's parent, grandparent, sibling, or partner. Threats to our residents' health are changing, and we must adapt to protect them. Multidrug-resistant organisms, or MDROs, are a known threat to nursing home residents. MDROs are resistant to multiple antibiotics or antifungals, meaning the drug has lost its effectiveness and cannot stop the germ. One way to protect our residents from getting hard-to-treat infections is to stop the spread of MDROs in our nursing home facilities. Unfortunately, many of these germs are often found in our facilities, on surfaces, and even on the hands of residents and staff. Residents can even have the resistant germ in or on their body without showing any signs or symptoms of active infection. This is a condition known as colonization. In fact, more than 50% of our nursing home residents may already be colonized with an MDRO. And because MDROs can spread undetected, we could unintentionally spread these germs when we provide high-contact resident care. This puts our residents at risk for colonization or a serious infection. Thankfully, enhanced barrier precautions are a way we can help reduce this risk. Enhanced barrier precautions, or EBP, are among many infection prevention and control practices that we should use when interacting with residents who are at higher risk of infection. We should use EBP for residents who have wounds, indwelling medical devices, such as central venous lines and urinary catheters, or those who have been colonized by or infected with an MDRO. However, if residents need to be on contact precautions, use those instead of EBP. So, how do we use enhanced barrier precautions? Much of the care that we provide for residents is close contact and hands-on, the type of care that is likely to spread MDROs. We should use EBP during the following resident care activities: dressing, bathing, transferring, changing linens, assisting with toileting, accessing indwelling medical devices, and providing wound care. So, before we enter a resident's room marked with an EBP sign, or before we engage in high-contact resident care activities, we need to gather all needed supplies and materials, clean our hands, and correctly put on a gown and gloves. Once we have completed our care, we need to safely remove and throw away our gown and gloves in the room, and clean our hands again before moving on to provide care for another resident. When we use these precautions for every resident who is at higher risk, we can help reduce or even stop the spread of MDROs. Enhanced barrier precautions may be new to many nursing home staff and will require each of us to use the mindset that, as soon as we encounter a resident with a wound, indwelling medical device, or MDRO, EBP should begin. By following this guidance, along with other important infection prevention and control practices, we can reduce the need for isolation, providing our residents with a better quality of life. This is a step in the right direction, balancing safety and quality of life while decreasing the spread of MDROs. Thank you for taking this step with us.
Now I'll pose these 6 questions that I like to think about when I talk about enhanced barrier precautions. I'm going to go over each of these questions in detail and talk about the who, what, where, when, how, and why of implementation. And I'd like you to think about and encourage an individualized approach when implementing EBP in your facilities. Think about how you can safely and effectively implement EBP to keep your staff and residents safe. Knowing the answers to these questions above will guide you in your approach to implementing this infection control actions for vulnerable residents in long-term care facilities. We know that during a global pandemic and nationwide shutdown, we saw residents become socially isolated, which has proven to be very detrimental to their overall health. EBP is a way that we can protect ourselves, we can protect our residents, and allow them to maintain their socialization within the facility in a dignified manner, lifting some of the stigma associated with infectious diseases and ongoing chronic diseases these residents are faced with in these settings. So the video did a good job of explaining enhanced barrier precautions, but we're going to dive a little bit deeper. So what are enhanced barrier precautions? Enhanced barrier precautions involve gown and glove use during high contact resident care activities for residents known to be colonized or infected with an MDRO, as well as those at increased risk of MDRO acquisition, for example, residents with wounds or indwelling medical devices. And where are we going to be seeing this implemented? So MDROs have a significant impact in nursing homes. Many residents are unknowingly colonized with an MDRO, especially residents with risk factors like indwelling medical devices or wounds. Residents who have an MDRO can develop serious infections, remain colonized for long periods of time, and spread MDROs to others. Healthcare personnel can spread MDROs through contaminated hands and clothing. And at this time, CDC has not recommended implementation of enhanced barrier precautions in other healthcare settings. However, the evaluation for broader application of EBP to other healthcare settings is ongoing. So we'll only be seeing these implemented in long-term care skilled nursing facilities. And again, why is this so important? Implementation of contact precautions, as described in the CDC guidelines for isolation precautions, is perceived to create great challenges for nursing homes trying to balance the use of PPE and room restrictions to prevent MDRO transmission with residents' quality of life. Thus, many nursing homes only implement contact precautions when residents are infected with an MDRO and on treatment. Focusing only on residents with active infection fails to address the continued risk of transmission from residents with MDRO colonization, who, by definition, have no symptoms of illness. MDRO colonization may persist for long periods of time, sometimes months, which contributes to the silent spread of MDROs. With the need for an effective response to the detection of serious antibiotic resistance threats, there is growing evidence that the traditional implementation of contact precaution in nursing homes is not implementable for most residents for prevention of MDRO transmission. During a study published in the Journal of the American Medical Directors Association in 2019, nursing home residents were tested to see if they were colonized with an MDRO. The second column in the table on the slide, highlighted in red, shows the percentage of residents who were colonized with an MDRO. In shifting the focus from actual infection to residents who may be colonized and taking into consideration the social and emotional burden of contact precautions, which may be in place for long periods of time, recent studies have indicated the use of EBP can effectively reduce the spread of MDROs while reducing resident isolation brought on by contact precautions. Why was adding another infection control action necessary? This study, along with containment strategies for outbreaks, have shown residents in nursing homes are at increased risk of becoming colonized and developing infection with MDRO. Nursing homes have been the setting for MDRO outbreaks, and when these MDROs result in infections, limited treatment options are available. So in 2019, the CDC introduced this new approach to the use of personal protective equipment called Enhanced Barrier Precautions. This new approach recommends gown and glove use for certain residents during specific high-contact resident care activities associated with MDRO transmission. CDC interim guidance recommends EBP as a strategy in nursing homes to interrupt the spread of novel or targeted MDROs. As described in the Healthcare Infection Control Practices Advisory Committee, or HICPAC white paper, Consideration for the Use of Enhanced Barrier Precautions in Skilled Nursing Facilities, dated June 2021, more than 50% of nursing home residents may be colonized with an MDRO. This report noted that the use of contact precautions to prevent MDRO transmission involves restricting residents to their rooms, which may negatively impact a resident's quality of life and psychosocial well-being. As a result, many nursing homes only implemented contact precautions when residents were infected with an MDRO. Based on available evidence and expert opinions, this white paper aimed to provide a consideration for broader use of EBP beyond targeted MDROs, including germs that affect every nursing home in the United States, such as Staph aureus, both methicillin sensitive and resistant. So in general, gown and gloves would not be required for resident care activities other than high contact activities unless otherwise necessary for adherence to standard precautions. Residents are not restricted to their rooms or limited from participation in group activities. Because enhanced barrier precautions do not impose the same activity and room placement restrictions as contact precautions, they are intended to be in place for the duration of a resident's stay in the facility or until resolution of the wound or discontinuation of the indwelling medical device that placed them at higher risk. So when contact precautions do not apply, EBP are indicated for residents with any of the following. A resident is known to be infected or colonized with a novel or targeted MDRO, such as Candida auris, ones we mentioned earlier, or resident has a wound or indwelling medical device, regardless of MDRO colonization status, and during high contact resident care activities. So EBP involve gown and glove use during the high contact resident care activities for residents known to be colonized or infected with an MDRO, as well as those at increased risk of MDRO acquisition. And as mentioned, there is no recommendation to remove a resident from EBP. An individualized, interdisciplinary team decision-making approach should be documented with a rationale for removal. For example, if a resident met criteria to be placed on EBP on admission due to having a wound, and the wound is now healed, and colonization in another body reservoir can be ruled out, then considerations can be made to discontinue. When implementing contact precautions or enhanced barrier precautions, it is critical to ensure that staff have awareness of the facility's expectations about hand hygiene and gown and glove use, initial and refresher training, and access to appropriate supplies. To accomplish this, post clear signage on the door or wall outside of the resident's room indicating the type of precautions and required PPE. For enhanced barrier precautions, signage should also clearly indicate the high contact resident care activities that require the use of gown and gloves. Make PPE, including gowns and gloves, available immediately outside the resident's room. Ensure access to alcohol-based hand sanitizer in every resident room, ideally both inside and outside. Position a trash can inside the resident's room and near the exit for discarding PPE after removal prior to exit of the room or before providing care for another resident in the same room. Incorporate periodic monitoring and assessment of adherence to determine the need for additional training and education, and provide education to residents and visitors. Now we'll look at contact precautions versus enhanced barrier precautions. So contact precautions are one type of transmission-based precautions that are used when pathogen transmission is not completely interrupted by standard precautions alone. Contact precautions are intended to prevent transmission of infectious agents that are spread by direct or indirect contact with the resident or the resident's environment. Contact precautions require the use of gown and glove use on every entry into a resident's room. The resident is given dedicated equipment if available, stethoscope, blood pressure cuff, and is placed into a private room if available. And when private rooms are not available, some residents may be cohorted or grouped together. Residents on contact precautions should be restricted to their rooms except for medically necessary care and restricted from participation in group activities. Because contact precautions require room restrictions, they are generally intended to be time limited and when implemented should include a plan for discontinuation or de-escalation. Enhanced barrier precautions expands the use of PPE and refer to the use of gown and gloves during high contact resident care activities that provide opportunities for transfer of MDROs to staff, hands, and clothing. MDROs may be indirectly transferred from resident to resident during these high contact care activities. Nursing home residents with wounds or indwelling medical devices are at especially high risk of both acquisition of and colonization with MDROs. The use of gown and gloves for high contact resident care activities is indicated when contact precautions do not otherwise apply for nursing home residents with wounds and or indwelling medical devices, regardless of MDRO colonization, as well as for residents with MDRO infection or colonization. And there are some examples of the high contact resident care activities outlined by the CDC. And we'll go over that a little bit more detail in a later slide. So here I just wanted to highlight some similarities and differences between the two contact precautions and EBP. PPE for enhanced barrier precautions is only necessary when performing high contact care activities and may not need to be donned prior to entering the resident's room, in contrast to contact precautions when PPE is indicated before entering the room. For example, staff entering the resident's room to answer a call light, converse with a resident, or provide medications who do not engage in high contact resident care activity would likely not need to employ EBP while interacting with the resident. And residents are not restricted to their rooms or limited from participation in group activities. Because EBP do not impose the same activity and room placement restrictions as contact precautions, they are intended to be in place for the duration of the resident's stay in the facility or until resolution of the wound or discontinuation of the indwelling medical device that placed them at higher risk. So now I'll ask for your participation and going over this quick scenario, and please use the chat to provide your answers. So Mr. A was admitted to your facility for short-term rehab after a 2-week stay at a nearby acute care hospital. He has a surgical wound on his lower leg and requires dialysis 3 days a week via an external indwelling catheter. On admission, what precautions would Mr. A be placed on and why? Go ahead and share your answers in the chat there. EBP. Good. Enhanced barrier. Very good. You guys got it. Enhanced barrier because of indwelling catheter, wounds, and devices. Great. Very good. So 4 days into his stay, he develops wound drainage, which is purulent, lethargy, and fevers. His wound culture grows a carbapenem-resistant Pseudomonas aeruginosa. Now, how would you proceed? Continue with EBP or change to contact? Precautions. Good. Contact precautions. Very good. So, so he'll now meet the criteria for contact precautions. Very good. And how will you communicate this with other entities, such as the dialysis facility, the resident, staff, and visitors? So how are you going to communicate this change? Any ideas? Perfect. Signage. Excellent. Sign on the door. Into disciplinary forms. Perfect. Write it on the COC. The continuation of care form should have a place to indicate infection status. Perfect. Very good. Mr. A is treated for a surgical wound infection, and his wound drainage has subsided and is contained. Should he continue to be maintained on contact precautions, or can he be transitioned back to EBP? Back to EBP. Perfect. All right, very good. So that's a good example of someone who is placed on enhanced barrier precautions, then gets sick, may need contact precautions for a short period, but then transition back. Very good. So residents in long-term care facilities are at risk for being colonized with these MDROs, and colonization can occur before or after active infection with an organism. These germs can remain in or on the body and not make someone sick. Being colonized with an MDRO does not mean the person cannot spread the germ, leading to the silent spread of infection. Thus, it is important to differentiate if a resident is colonized or actively sick with infection. It may be helpful to implement a protocol to determine if signs and symptoms of infections are assessed and create a criteria for initiating contact precautions empirically if a resident on EBP develops increased wound drainage, loose stools, or other systemic changes as listed on the slide, including how you will communicate the change from EBP to TBP to staff, residents, and others involved in the care of the resident. Great job. Thanks for participating in that. I appreciate that. So who in your facility is going to meet the criteria, and how are you going to keep track? Who in the facility meets the criteria for EBP? Remember, your facility-specific policy should indicate the criteria decided on based on an interdisciplinary team decision-making approach. After taking into consideration factors such as MDRO pressure, antibiotic use, and resident acuity, a documented facility-specific criteria should be outlined to limit any confusion as to which residents meet criteria for use of EBP. And there on the slide, you'll see which residents should meet the criteria. So you guys did so well on the last scenario. I have one more for you that we'll go over. So in using EBP, you'll be providing an additional level of protection with gowns and gloves as a barrier for potential pathways MDROs can enter the resident's body. You will be protecting the most vulnerable from potential infection. So let's put this into practice. So in this scenario, your facility has not yet implemented EBP. You are administering a nebulizer to your resident via open tracheostomy. The resident had a positive sputum culture that grew a pan-resistant Pseudomonas aeruginosa during their most recent hospital stay 1 month ago. They are in recovery and recently finished a course of IV antibiotics. The resident is considered colonized with Pseudomonas aeruginosa. What type of PPE should you use while assisting with a nebulizer for a patient with an open trach? What infection control risks do you anticipate in this scenario? All right, go ahead and share your answers there in the chat. We have N95, gown and gloves, droplet precautions, droplet, gown and gloves, eye protection. Good. So you've used your clinical judgment and decided to use standard precautions, including the use of hand hygiene, use of gloves, a surgical mask, and eye protection during this activity. You don all appropriate PPE and enter the room. You approach the resident to perform a respiratory assessment, and the resident coughs. You don't realize your clothing has become contaminated through splashes and sprays of sputum from the cough. While you are in the room, the resident requests suctioning and assistance with repositioning in the bed. You proceed to assist with these activities. Would you consider any of these care activities to be high contact care activities? So again, while you're in the room, the resident requests suctioning and assistance with repositioning in bed, and you proceed to assist. Would you consider any of these high contact care activities? Yes. Perfect. Suctioning, repositioning, both high contact. Very good. Yes, so those would be considered high contact care activities. So you finish caring for this resident, doff all PPE and perform hand hygiene. You then move to another room to assist a different resident with urinary catheter care. You decide to use standard precautions, including hand hygiene and glove use. You lean over the bed and your clothing touches the catheter tubing and linens, potentially contaminating the catheter and linens and likely entering the body through the pathway urinary tract. How could have transmission been interrupted in this case? What additional infection control actions could have been used to stop the spread of infection? Gown could have prevented the spread. Perfect. You guys are on it. Great job. By adding the additional layer of protection using a gown may have interrupted the spread of the CRPA to the vulnerable resident with the urinary catheter. Excellent. Excellent job. Thank you so much for participating. So in addition to standard precautions, use of EBP during these high contact resident care activities, and these have been outlined by the CDC, and remember, this list is used for reference, and EBP applies to all these activities. There may be additional activities and needs for each individual resident. Being transparent with all care providers on what is expected for each resident while implementing EBP can lead to successful outcomes. Also, it is important to document rationales using evidence-based and interdisciplinary protocols behind all decisions regarding EBP as to eliminate barriers for personnel during implementation at the bedside. So this list includes bathing, showering, dressing, transferring, changing briefs or assisting with toileting, wound care, device care, providing hygiene, and changing linens. So how do you begin? Where do you begin with implementation? Developing an action plan with facility leadership is essential and vital to success. So you have to ask yourself, what goals do you have for implementation of EBP? Will you be implementing facility-wide to start or just on a specific unit with high-risk, vulnerable residents, then expand to other units? Which residents are you going to include? Does your facility have a designated person for confirming which residents meet EBP criteria, or can anyone place residents on EBP? Who will be responsible for ordering and stocking PPE? How will you communicate to residents, staff, and others involved in their care? What is expected once implemented? How will you address any barriers to implementation? How and when will audits occur to monitor gaps in practice? And when breaches do occur, what education tools will you be using? What is your plan for providing feedback? A systematic approach to implementation involving leadership with a focus on key areas such as resident assessment, including infection status and presence of wounds or devices, auditing and feedback, interactive education and tools to foster adherence, and communication with all involved in care as to what is expected are some key strategies to successful implementation. And CDC has recently developed this pre-implementation tool for use in skilled nursing facilities, and it's designed to be used prior to implementation of EBP in your facility, either a unit, wing, or entire facility, as a guide for developing a successful plan for the implementation of EBP during high-contact resident care activities. And Abby will be providing a link for this tool in the chat as well, so you can have that available. It's an excellent reference. And they've also developed this new tool, this observation tool, and it should be used after establishing the use of EBP in your facility and can be customized to meet the needs of the skilled nursing facility. This tool is designed to support the conducting of observations of healthcare personnel using EBP during high-contact resident care activities as part of auditing and feedback. And responses should refer to current practices. And it's also helpful to guide leadership in developing useful tools to assess residents for use of EBP safely and effectively in the facility. And Abby has posted this link as well in the chat for your reference. And here's an infographic developed by the CDC that can be posted in your facility to help educate staff, visitors, and residents on why we're implementing EBP and what they need to know. And also they have this handy little pocket guide that can be printed out, and Abby's sharing the link to that. It's a tri-fold little pocket guide you can keep directly on you at the point of care, just to make sure if you have any questions, you can refer to that. Make sure you have all the information available right at your fingertips. All right, very good. And our key takeaways for today's session: MDROs are a major health threat to residents in long-term care facilities. Implementation of infection control actions, such as standard precautions and EBP, are recommended by the CDC as an effective strategy to reduce the spread of MDROs. And using an individualized approach to implementation can be useful in assuring successful outcomes. And please check out our website for our live events that are upcoming. And you can follow us on social media. We have reminders and posts for infection control and our upcoming webinars. And we have upcoming sessions: measles in a healthcare setting, an infection prevention and control refresher coming up April 29th. That's tentative. And keep checking our website for sign up for that event as well. And we have some more webinars coming up in May for cleaning and disinfection and sharp safety. And here are our references. And just a reminder to receive your certificate of training, please fill out our post-session survey, and that will be emailed to you. Oh, I forgot to change the dates here, but that will be emailed to you tomorrow. And then the post-session quiz, if you would like to receive continuing education credits, and those will be emailed out to you. and then you'll receive your certificate via email. We have just a quick poll, and then we'll go right into, we have time for a few questions. If you want to take that end of session feedback poll, just a few questions, and then we will go into our Q&A, and I want to be mindful of everyone's time today. We are scheduled till 11, so we do have time for just a few questions. And we've hit time, and I think that's all the questions we had. I didn't see anything in the Q&A box. So I'd like to just thank everyone so much. If you have additional questions, feel free to email us. We are available all the time, and we will respond to your questions via email. And again, thank you so much for being here, and I hope you guys have a great rest of your day and hope to see you in the future.